4% of the time when you intubate a patient, because of that intubation, within minutes, you'll be up doing chest compressions on that patient. 4% of intubations in the emergency department end with post-intubation cardiac arrest. And if that happens, there's an 84% chance that patient will die during that hospitalization. Let's talk about how to not kill your patients. First thing is we've got to identify those at risk for post-intubation hypotension, post-intubation cardiac arrest. I like the 4 H's. My first H is hypotension. If they're hypotensive going into it, that's bad news. Secondly is hypoxia. We need to identify this and prevent this to prevent arrest. Next is the hydrogen plus or the proton or pH. If your patient has a severe metabolic acidosis, intubation is a very scary thing for that patient. And my last H probably could have been under hypotension, but I like to think about the right heart specifically because these patients are at a special risk for post-intubation collapse. Let's go through the H's. First H is hypotension. Obviously, this patient, we're going to resuscitate them before we intubate them. They're tachycardic, they're hypotensive. This is a no-brainer. I don't think anyone would miss this. We're going to get fluids going. We're going to get pressors on. We're going to do an ultrasound, make sure we have identified the reason for their hypotension, and we're going to intervene. But what about this patient? Blood pressure is not enough. Heart rate's not enough. You got to combine the two and look at the shock index. Shock index is very simply the heart rate divided by the systolic blood pressure. So for example, in this patient, if we're going to calculate their shock index, their heart rate is 100, their systolic blood pressure is 100, 100 divided by 100 is 1. Their shock index is 1. Anytime your heart rate is higher than your systolic blood pressure, you need to be worried about that patient and you need to resuscitate that patient before you intubate them. We'll do a couple more math problems here. On this patient, my heart rate is 108, my systolic blood pressure is 102. When we populate that into our calculator, we get a shock index of 0.9. For all comers, if your shock index is greater than 0.9, this is a patient you need to be worried about. This is a patient that's potentially unstable. You're going to be really good at calculating shock indexes by the end of this. This patient has a heart rate of 120. They have a systolic of 150. When we plug that into our calculator, we get a shock index of 0.8. A shock index of 0.8 or greater predicts post-intubation hypotension with a sensitivity of only 67%. We may miss a third of our patients that are at risk for post-intubation hypotension if we use a shock index of 0.8. Last math, I promise. This patient has a heart rate of 105, a systolic blood pressure of 150. Their shock index is 0.7. The Society of Airway Management recommends that every patient that has a shock index of 0.7 or higher, you make preparations for post-intubation hypotension. Now, in order to make preparations, you got to know if they're hypotensive. You are responsible for setting up your monitor. Make sure that's set to cycle every 3 minutes during your intubation attempt, or push that stat button, which will cycle blood pressure after blood pressure after blood pressure. Or if you have time, if you can delay the intubation, throw in an A-line really quick so that you can have beat-to-beat blood pressure measurements and know immediately if your patient is starting to crash. And be prepared. Have your vasopressors going. Even if your shock index is 0.9, have levo hanging primed, ready to go. If their shock index is 0.6, still have some push dose epinephrine ready just in case. Going back to our H's, our second H is hypoxia. Every patient is at risk for hypoxia during an intubation attempt. Every patient gets pre-oxygenated. If you put this non-rebreather on them and you set the fluid flow to 15 liters, that's going to get us an FiO2 of about 57%. This is based off of exhaled oxygen concentrations. That's not great. However, if you turn that knob and keep turning that knob to what we call flush rate, that's going to get you an end-tidal oxygenation of up to 86%, which is actually pretty good. This is the minimum that you need on every patient, a flush rate non-rebreather. Other ways you can pre-oxygenate, if you have a high flow nasal cannula putting out 40 to 60 liters per minute, that gets you end-tidal oxygen of about 76%. That's pretty good. It's still not positive pressure though. The advantage to this is you can leave it on the patient during the intubation attempt and get some passive oxygenation going. Other options would be a bag valve mask device, but the key here is you got to have a PEEP valve on it. You put the PEEP valve on your exhalation port, and you've got to hold a tight seal through exhalation to hold that pressure in. When you do this, you're getting an end-tidal oxygen of 77%, which again is pretty good, but you're also getting some positive pressure, which can recruit more alveoli, which can increase your residual volume, which can give you more apnea time before they tank. Your other option will be non-invasive ventilator. So a BPAP or CPAP, some kind of non-invasive ventilator set to 100% to pre-oxygenate. This actually gets you the highest end-tidal oxygen readings of up to 88% and gets you phenomenal positive pressure, which will recruit more alveoli. If you have a patient that you're concerned about, if they're having oxygenation issues, pre-oxygenate them with a non-invasive ventilator to give you the best chance of avoiding post-intubation collapse. Going back to our H's, we had hypotension, we had hypoxia. The next H is our pH. Let's look at this patient here for a second. Comes into your ER with a blood sugar of 600, breathing 40 times a minute, looks terrible. You make the diagnosis of DKA. However, he's not protecting his airway. And by that, I don't mean he's altered. I mean he's actively vomiting and aspirating. We don't intubate these patients for ultimate success. Let's say he's actively vomiting, actively aspirating. We realize we've got to take this airway. His vital signs already don't look good. His shock index is 1. He's at risk from hypotension. His O2 sat, because the aspiration is only 92%, he's already at risk for post-intubation hypotension. But what puts him at the highest risk is this. Let's say his pH is 7.1. He's breathing really fast. He's got his PCO2 down to 10. His bicarb's only 5. If I allow his PCO2 to go from 10 to normal, to 40, which is still normal, his pH is going to plummet from 7.1 down to 6.8, and he is going to die. He is going to code. The best way to manage these patients is to not intubate them in the first place. Secondly, if you have no choice but to intubate them, and your indications for this are 1, not protecting their airway in that they are actively aspirating and you can't stop their emesis, you may have to intubate them. Older patients will tire out. If you see that respiratory rate go from 35 to 25 to 15 and they're not getting better, they're about to go apneic and they're going to code. You're going to have to take over and support them. If they have to go to the OR, if they perforated their bowel and they're fluidly septic from it and they've got to go to the OR, and that's what threw them into DK in the first place, they're going to have to be intubated for the operation. That's not an option. And then finally, if they were like a severe pneumonia or severe COVID, and that's what put them into DKA, and you cannot oxygenate them and you have no other choice because of their pulmonary status, you may have to oxygenate them. Avoid intubating these patients at all costs. Secondly, if you do intubate this patient, you've got to minimize apnea time and resume hyperventilation as quickly as possible. This is going to be a true RSI. I'm going to push either high-dose rocuronium or succinylcholine to have a very fast onset. I'm going to have my most experienced person doing this intubation. This is not a learning intubation. Remember, slow is smooth, smooth is fast, so I'm not going to rush, but I'm going to do 1 quick pass, secure the airway. As soon as my BVM is on there, I'm going to resume hyperventilating them. I don't want to give them too much volume, but I want to keep my rate around 30 if I can, and I want to hyperventilate them as much as possible to prevent post-intubation collapse. Let's go back to our 4 H's. We've talked about hypotension, we've talked about hypoxia, we've talked about the hydrogen ion. Let's talk about the right heart. This can probably be lumped into hypotension, but I like to think about it separately because this is it's really its own thing that can cause post-intubation collapse. So ordinarily, my right heart, my right ventricle is kind of weak, it's kind of wimpy, it's thin-walled, it forces blood through the lungs back to the left side of the heart. Doesn't have a hard job. However, if I put a giant clot in the way, now I'm going to significantly decrease the blood that's going to get out of the right ventricle. And this is why some PE patients, when they hit that PE, when it hits the lungs, they just collapse and die because no blood can get out of the right ventricle. Let's say I've got out just enough to keep my patient alive. Now all of a sudden, I put an endotracheal tube in the trachea. I fill the lungs with positive pressure. That's pushing back on these pulmonary arteries. I've just put a ton more afterload on that right ventricle that's already struggling. I can cause sudden cardiovascular collapse by intubating a patient with a pulmonary embolism. If you've got a PE and you've got to intubate, go ahead and have your vasopressors ready. I like vasopressin for these because it doesn't have as much effect on the pulmonary vascular resistance as norepinephrine does. If they're hemodynamically unstable at all and you're having to intubate them, give them systemic thrombolysis first. Try to break up that clot some so they have more space to get blood through. Prepare for post-intubation collapse in these patients. That's it. That's my 4 H's. My take home is every patient's at risk for collapse. Prepare for it on every patient, but specifically think about these 4 things before you intubate.